Hello, and welcome to the next episode of the ReSPECT podcasts. So we're doing a series of podcasts to try and help staff feel more comfortable with the ReSPECT process and to hopefully bust some myths and get people to realise why it's such a great thing to do and why I love doing it so much. So my name is Tanya de Weymarn. I am an emergency medicine consultant at Gloucester hospitals. I'm also a frailty consultant and I'm clinical lead for end of life for the ICB, but I do lots of other things as well. And I have a huge love of the ReSPECT process because it allows us to provide patient-centred care. And I am here with some people today who I am going to let introduce themselves because I will talk too much.
Hi, I'm Rachel Bucknell. I am a Frailty Matron at Asper Medical Practice.
Hello, I'm Jo Murray. I'm Services Coordinator for a Gloucestershire charity called Guideposts Trust. We have various groups and services supporting older people living with dementia and those caring for them.
Hi, I'm Louise Balson, the South West Ambulance Service clinical lead for Gloucestershire.
Fab, thank you. So today what we're hoping to talk about is about the benefits of ReSPECT and why it's such a great thing. So less about how you complete a ReSPECT process, but more about the benefits that we've seen or that we've heard about for the individuals and health professionals and the organisation and anybody else that we can think about. I think the first question I want to ask is, does anybody have any myths to bust? Anything that they've changed their opinion on over the period of time? Silence. So maybe that's an unfair question.
Oh, well,
Okay.
well, actually, Tanya, I'll jump in, and I'd say the myth for me as the non-clinical person here, and we were just talking about that, is the myth that actually it is a good subject to talk about. You need to be brave and start it. And in my experience in the world that I'm working in, the people that I'm having that conversation actually, in the main, are very pleased to be able to have the opportunity to talk about it. But it is tricky. Mm-hmm. You have to just do it. We're lucky that we're not talking about it in an emergency situation, so we can talk about it alongside other things. You know, have you got the right aids and equipment in the house? Are you getting the right benefits? And what might happen to you in a medical emergency? So I'm probably lucky to be able to have that conversation in a non-clinical setting. But the myth that to bust is just start it, because I think you'll be surprised how keen people are to talk about it.
Yeah, and I think that's a myth that definitely since I became aware of ReSPECT, and we've always had some form of what to do in an emergency plan, but I think ReSPECT, the myth is that it's a depressing subject for me and that patients don't want to talk about it, because actually a lot of people have thought about this, and for most of us the unknown is much more scary than the known, and knowing that your wishes will be listened to, and I find it really uplifting to actually spend that time with patients.
I think my myth, Tanya, is anybody over the age of 18 should be thinking about what they want and completing a ReSPECT form. You do not need to be old or poorly to have one.
Yeah. I think even if a ReSPECT plan is too much, and gosh, it's when you're younger, it's hard to think about what you're going to summarise and put down on that one piece of paper. But I guess the more extensive way to still get those benefits is to make sure that you've got your lasting power of attorney. And I think that's really important, that ReSPECT and lasting power of attorney very much go hand in hand. And that I think it's a common myth that people think that your spouse or your next of kin can speak for you if you're unable to speak for yourself. And that's not the case. We will always listen to next of kin in a best interest discussion. But in order for them to really make decisions on your behalf, they need a lasting power of attorney. And for me, my lasting power of attorney's been in place for 20 years. It's not about my fear of developing dementia. It's that what happens if I have a car accident on the way home. And I think everybody wants to know their voice will be heard, whether that's through lasting power of attorney or a ReSPECT plan. But knowing what matters to people is really, really important. This is not, and I think you're absolutely right, this is not about people just at the end of their life. This is all the way through. We need to take out that insurance policy and hope we never need to use it.
Normalise the conversation.
Yeah.
And I think to add the other little bit of myth on that is people say, well, I'll get my will sorted and then I'll think about power of attorney and ReSPECT planning. And again, we're able to say, well, perhaps we could turn that around and those other two things are more important than the will. It's just about people's understandings of the systems.
Yeah. I mean, to me, it's much more important to know what's going to happen to me while I'm alive rather than what's going to happen to my stuff after I've gone. But
yes.
So you plan for a holiday, so why wouldn't you plan
exactly
to ensure everybody knows what you want?
Absolutely.
Yeah.
Especially when it's something that's inevitable. Yeah. And we're not just talking about death, but, you could have an accident. And you're right, Rachel, that it's not just about dying, but about what you want in regards to things such as, do you prefer to have a shower or a bath? Do you want to have specific things taken into hospital with you? Who do you want to contact in an emergency? Those things that are really important to that patient, those are the things that we like to see on those ReSPECT forms. It's not just about what you want to do in case of potential death.
Yeah, we'll all have an emergency at some point.
Yeah.
And having that plan in advance is so important. So I guess if we go through a patient journey, Lou, you and your guys are often the first ones to respond to that emergency. Tell us what a good ReSPECT plan means to SWAST or ambulance service and what a bad one does and how it can change things, or no ReSPECT plan, those sorts of things. What difference does it make? So
we want to treat every patient with dignity and compassion and do the best for that patient and give them the outcome that is what they would want. Without a ReSPECT plan, for those that are either entering the end of their life or have comorbidities, not understanding what they want from the treatment that you are potentially going to provide them can have a really adverse outcome. Do they want life-sustaining treatment? Or do they want comfort care? Would they want to go to hospital, or would they like to die at home? All these things are really important to make sure that that person ends their life or enters into a different stage of their life in the best possible position that they want to be in. So a good ReSPECT form wouldn't say things such as for ward-based ceiling of care, wouldn't just say non-invasive interventions. That's very grey. It leaves us with very little information to know how far we can go. And because ReSPECT is it's not a legal document. It has to be used in conjunction with clinical decision making, and we want to do the best for the patient. We will look at best interest decisions with using the information on the ReSPECT form. But if there's no information on there or a very small amount of information on there, making that best interest decision is then based upon our clinical decision making and not necessarily what is best for the patient with their own wishes, because it's not documented.
And it's based on your value judgment. So what's important to you as a clinician might not be what's important to that. So
exactly right.
Even though you're subconsciously doing it, you're sort of forcing your views on somebody because you do the best for them, but you have to make the assumption
you're
that they
using
have
your
the same
morals,
values.
what would you want for yourself or your own family? But yeah, you're right. That's not necessarily what that person wants at all, or what their family want for them. It can be really, really difficult. And of course, our clinicians just want to do the best. But they need to know, does this person want their life sustained? Because that is predominantly what paramedics do, is sustain life. Or do they want comfort care? Where do we draw that line with regards to the management of that patient? without knowing, it can be really, really challenging for them.
And I think I've done some work where I'm taking calls off ambulance staff at the moment. And I think there's something about people having a really good idea about what the right thing to do is, but it might be a slight diversion off the easiest course, and having that back, when you think you know what the right thing to do, but having it written down that actually, I think this is the right thing. Oh, yes, that reassurance that you are doing the right thing, even though it's not the conveyor belt option, is I think really useful to help you guys do what you think is the right thing for people.
Yeah. And we do have clinical guidance around these kind of incidents, but they're very wordy, very lengthy. We want, because the guidance wants to cover all bases. But what we would really encourage our staff to do is, if they're in a position where they're thinking, is this the right decision for the patient, they can call one of our senior clinicians and have that joint conversation about what do we think is the right thing for the patient. So we really encourage our staff to do that before they make any decisions that either they are not comfortable with or they're questioning whether it's the right one or not. But I think we still need to get the message out there to our staff that is in place, and you need to be considering that before you're thinking about doing something that you're not quite sure about.
Yeah, absolutely. Length of information, I'm glad you brought that up, because we were actually talking about, go on, you say what you said in between.
I was saying it would be nice sometimes to have a longer form, because getting some of the information on there, it's only a small section, and actually what I didn't realise is you're happy for us to pin stuff to it. So that's something that I have learnt today. And we do put stuff in a summary care record, but we're never quite sure how much you guys can see. So it's all in the detail, isn't it? That's certainly a message I'll be taking back to my team, that we can put extra, we can clip it on. Yeah. Definitely make sure it's in the summary care record. I think
the safest assumption, and my dad was horrified when I told him this, is that assume that the other healthcare professionals can't see anything on computers and things like that. So giving us it in, and even if we can see it normally, computers go down. So having that backup is so important. But when you said you wished the piece of paper was longer, my response was, I'm glad it's not, because in an emergency, I don't want too much information. I acknowledge that it's really useful to have it there, but I want that summary. And I think what's really important to say about the ReSPECT plan or the piece of paper is that it is a summary of what's been discussed. And if we are discussing something as professionals, we still need to make sure that although we're writing that summary on a purple piece of paper, we still back up the full conversation in our clinical notes, which people might not have access to. And I know there's members of the specialist palliative care team who will regularly staple a piece of paper to the back of the ReSPECT plan, because I want that summary at the front almost like an index before I get to the longer plan. And once that immediate decision's been made, we might have time to then read into the more detail. So I think it is important that we know that staple to the back of it, that's fine. Add bits, refer to the Me at My Best or whatever other documents, and write that in your recommendations. Even if it's not stapled to it, you can say, please refer to for more details. Or what I do love, and you'll like this, I love it when it says, please speak to Frailty
We do put that on
Matron,
our form.
9 to 5 Monday to Friday, or 8 to 8 Monday to Friday, and then a little phone number. That makes me very happy, because anything we can do with a ReSPECT plan to break down these silos and join up everybody's thinking is always really important.
Our frustrations come when the plans go missing. So I had a scenario this week where we had to call SWAST, and we searched the place. they could see it on the summary care record. It was there, it was coded, and we happened to have one because we'd gone out to do a visit and had to call 999. So I was able to hand that over. They have one, and I promise you they have one. And actually, I'm so close to the hospital that I just went and printed another one and walked it down to pit stop.
Yes.
And said, but we do have a lot of incidents where you do the groundwork, and then I've had people where the relatives have taken it home and they might live in Surrey. And I'm like, it's no good there.
Yes.
Or they go into hospital and it magically disappears because it gets coded into the notes, and then for a number of reasons it doesn't travel back out.
Yes.
And I think we were talking about this earlier, because I'm very much working in the community with people, hopefully before they're coming into hospital. But part of my role is to emphasise the importance of that orange folder with the ReSPECT form and say you need to keep that really prominent. It's hugely important, but it's not so important. It should be locked away under lock and key. When the ambulance arrive, it would be really helpful if you greet them with that orange folder and the ReSPECT form. And you take some responsibility for it on its journey around the hospital, because ideally it'll come back again.
We always say, show it them, don't let them keep it.
Yes.
Say, no, it's mine. It's like your passport. Don't let them have it.
Yeah.
Yes.
And we
It's
talked,
hard to
didn't we,
touch
about
it.
taking a photograph of
Yes.
relatives in
So that's
Surrey.
a big recommendation, is it goes on people's phones
yeah.
as well. So that
Because we also give out the green messages in a bottle, so I say to everybody, put a bit of paper in that and say where your ReSPECT form is.
That's a great idea, because a lot of staff still look for those.
Yes.
For people that don't know about the message in the
Yes.
bottle, will you tell us how? Because I give them to everybody, but people go, ambulance staff are not going to look in the fridge.
Oh,
so let's
they
myth
do.
bust.
They absolutely do. And not just look for a message in a bottle, but just to see what's in their fridge.
Yes.
It tells you a lot about a patient. But no, they do. They will look. Normally it's in the door of the fridge, and it just gives a little snippet of information about the patient, which is super, super helpful. It's great because everyone has a fridge. Most people have a fridge. Everyone has a kitchen. It's an easy place to go and find it, because you're right. Sometimes we don't know where that ReSPECT form is in the house. It could be filed away in a cabinet, locked up. It's not always with the patient. So the message in a bottle is a fabulous idea.
one of the problems we have with the message in the bottle from a GP perspective is they charge us for them. So we don't have a budget for them. So it's then we have to then rely on the family member supplying it, and that doesn't happen. So that's a real sticking point for us. Is we'd love to have them, but we don't have an endless budget to buy them.
Wonder who we need to speak to get you some. Obviously, if people wanted to keep stuff elsewhere, so one of the great things about the message in the bottle is it comes with a little label that highlights the fact that there is something in the fridge for you, not chocolate gatto, different things. Yeah. But, I mean, I think it's about having, and the orange folders are superb because they're so easy to see if your house is tidy. In my house, you'd be looking in the piles of paper. You still wouldn't be able to find an orange folder. Mine will be on the fridge. I can tell you it's there now. But I think it's about communicating where we can find it. But I do love the message in the bottle. The other place, if you can get a stock. So my parents have one message in the bottle between the two of them in the fridge. But they also have one in the glove compartment of their car now. So if they have a car accident or whatever, you will find a photocopy of their ReSPECT plans, plural, because they each have one, in their glove compartment. And because they don't care about their car, that it's actually stuck to the dashboard, that it says it's in there. Or maybe I don't care about their car and do it for them. So I think that's the thing, making it as easy as possible for people to hear what matters to you and not trusting the computers to do it for you as a patient is
I've got
really
an interesting
important.
question.
Go for it.
Can paramedics write a ReSPECT plan? And would you?
Well, this is something that I wanted to bring up in the myth part of the conversation. So as far as I'm aware, yes, we can. I don't think we do.
Because we get a lot of requests saying they don't have one. Can they have one, please?
That's great. What, from paramedics then?
Yes,
That's
or they
really
haven't got an
good.
orange folder,
Okay.
or they haven't got this, that, or the other.
Well, that's good.
I'm
going to
do my happy dance.
Yeah, that's great. And yes, by all accounts, they can add to it. But again, I don't know if the confidence is there. But the fact that they're bringing it to your attention is wonderful. That they're seeing that person is in need of a ReSPECT plan. Yeah, that's great news.
So I think one of the problems is they don't carry them. So they, the amount of stuff you carry in an ambulance is pitiful compared to what I carry in my camper van. And you really could fit so much more in it. But apparently big piles of paper is not the easiest
Sadly.
thing. And I think the thing with any ReSPECT plan is that anybody can write on the piece of paper as long as they are competent to do that part. And that's why it's an MDT, multidisciplinary process. Thank you. Sorry, couldn't think of the word. So what I generally say to ambulance personnel is what we were talking about in the last one, that they will hear that stuff that people don't say otherwise, whether that's, I can't go to hospital because of Ronnie, and you go, who's Ronnie, and find out it's their pet hedgehog. Or I had such a hellish time in ED, I don't want to go back there. Or I can't leave my wife because I'm the carer. And they also see things that other staff don't see. So they see the little cottage that's on 15 different floors with steps everywhere. Or they see the hoarding. I learned there's a hoarding score. Love that. Yes. You can write that down. It gives me something to Google to work out what it is. But paramedics particularly are eyes and ears when it comes to being in hospital. And so I've definitely encouraged paramedics to add those sort of things. When it comes to clinical recommendations, for anybody, it needs to be within your level of competence. And I generally say that adding things that we will do is probably in most people's competence. And I think you mentioned in the last episode about you will write lots of suggestions of other alternatives.
We will. So we'll suggest synapsis, we'll suggest single point, frailty teams, district nurses, rapid response. We'll say consider all of these first before we think of the ultimate decision to take someone in.
And I think writing these down is particularly important because SWAST is not just Gloucestershire.
No, indeed. Yeah, we have clinicians come up from Bristol, across from Swindon, even clinicians from Wales. So, yeah, they don't know the intricacies of the county, so having it written on the plan is ideal so that they don't need to search and try and find who it is they need to be speaking with. That's fabulous to hear.
And even if they don't know what synapsis is, they can ring their
find out.
specialist paramedic, and get someone to translate.
Exactly.
For anybody that doesn't know, because we've mentioned synapsis a couple of times, it is a facility where certain health professionals can ring and have a recorded conversation with hospital specialties. So again, breaking down those barriers and actually doing joint decisions to make the right plan, or maybe getting some senior support, or what depends what we need. And I think it's not just about senior support, it's about using those expertise of the person on the end of the phone. And that brings me back to who can write the clinical recommendations, and you need to be within your competencies. So you can write positive things that you might know about that add stuff. I think you need to be more careful about taking things away, because you might not know all of these, but if you're adding options, that's easier. And I think if we are saying that people wouldn't benefit from things, I mean, I've been a consultant a few years. I'm not going to say, because it shows how old I am. But there will be times when, even though I'm very comfortable in ReSPECT plans, I need to ring my renal colleagues, or this weekend I emailed my respiratory colleagues and asked them for advice about that. So we will need other people But that said, there will be some patients that I have all the expertise to make that plan. And I think the clinical recommendations are trickier because you do need the knowledge to do it. But add in suggestions. But definitely those top boxes about the scene setting and the summary of what's going on in people's lives, and when they tell you what they value and fear is so important. And yes, I don't have a problem with ambulance personnel starting them, but I doubt they're carrying the purple bit of paper. I think some of them do in their back pocket.
Yeah. And I think you were saying you were taking something away. Actually, this is a really important takeaway for me, because in the community I'm giving people options about what's available. I'm not telling them but what's available. And actually this is brilliant for me, because I can say to them, they say, well, I want to go to hospital, but I've got no choice. What I've learned is that I can actually meaningfully help them to have that own empowerment to say, maybe I don't want to go to hospital, but I know there's other choices. I can't remember the names. I don't know what there are. And they can have that, or the family can have that conversation. So that's a really useful takeaway for me. I've just made a note and I'm going to add it to when I have that conversation.
I was thinking about a scenario that we've got at the moment. So we've got a very young male dementia patient, and his wife wants to do the best. And their son is an oncology specialist nurse. And so we've had the conversation around the ReSPECT plan, and she doesn't know what he wants, and she's scared. So actually what we've done is we've left the plan, and her and her son are going to sit down and write something together, so that then she feels confident that we're making good decisions for her husband and we're advocating, and that's then going to lead on to another conversation. So it's not going to be the final plan, but it's given her the confidence with someone she trusts, her son, who works in a nurse specialism, who understands the mechanisms of dementia and frailty. So I think in those scenarios where you maybe have got a health professional but is on the family side, is still being able to steer that conversation. They're not making the decisions, but they are enabling other family members to feel a bit more safe and secure in the decisions. I think you've got to use all your tools in the toolbox at the end of the day. And we'd really like to have a ReSPECT plan for this patient, because we can see the trajectory that they're on. So doing it that way and doing it slowly, I think, will be a real benefit to that family.
To clarify, patients and individuals shouldn't be filling in the form by themselves. It's not a problem to leave a form so they can see what sort of things are being discussed, but we have had the odd incident where people have completed it themselves because they've misunderstood the point of it. So it does need to be a two-way discussion at all times. You know, we need the health professional input as well as... So I don't have a problem being with the piece of paper being left with people as long as they know that it's not for them to... Yeah,
so that expectation is there. It's left so... And it was left with the ReSPECT guidance.
Yes, love it. The form's useful.
And I also sent them a video because just so the wife can get it in her mind what it is. And we know that won't be the final ReSPECT plan. I'll be able to just have a look at the conversation she's had with a relative, and then we'll write it proper.
Yeah.
But we felt it was so hard for her to even engage in that conversation. We had to start somewhere.
Yeah.
Yeah,
no, I know you wouldn't, but it's just to clarify for anybody listening. I think what you've just said there is really important, that people don't have to have capacity to have a ReSPECT conversation. And unfortunately, I saw a poor ReSPECT plan this week where somebody didn't have capacity. They've never had capacity to make decisions about their healthcare throughout their life. And really sadly, somebody had written that the patient cannot express what matters to them over the values and fears bit. And I think that's a real missed opportunity with the ReSPECT plan, because when you're called, Lou, we won't necessarily have the right people there that can talk about what matters to that person. And
that's a really good point.
We've got a real opportunity of benefit that because this is done in the cold light of day, it's not an emergency. There is the option as and what should be happening as healthcare professionals is that we are carrying out the best interest conversation, but before it. And Caroline Pennells, our legal eagle, will be able to advise much better than this, but she'll be very proud of me for saying that in a best interest conversation, it is our responsibility to make sure that we seek information from wherever we can get it. And I think that's a really important part of ReSPECT, that in many ways we're carrying out that best interest discussion. So it might be appropriate to speak to a lasting power of attorney, but also those people that know a person best, look at any previous conversations. There's lots more places, but I'll forget. Body language. And actually observation, that if for somebody the biggest priority is sitting in the garden and they hate being in a noisy environment, we can use that, but also expert knowledge, like what might be good for most people with dementia, will guide our choices and best interest discussions. Even if we can't individualise, we can definitely be guided by different experiences and knowledge, I think.
And I think that, doesn't it come back to what you were saying earlier about, even for us writing down whether they live in a rural bungalow, whether there's a spot, if we can capture that for those of us that are going into the house, that gives you an idea of what their values might be. I know we're in danger of making assumptions, but it does give you a snapshot, doesn't it?
Absolutely does. I remember a lady being in tears because she was so pleased when I said, I'm not going to... She was a lady who had been an alcoholic for many years and was dying of her alcoholic liver disease. And actually, maybe we should have... She said to me she was so fed up of people telling her to stop drinking. It was too late. It wasn't going to change anything. And maybe we should have taken an assumption from that maybe she didn't want to stop drinking. And we can make judgments from that. But actually, at that point, she was able to talk to me and said, oh, I'm so happy. And I sort of wrote down that she values being able to drink. And so we can make judgments from people's history. And if somebody has always enjoyed a whiskey for their entire life, they may have lost capacity now, but let's pull on that as well. So I'm aware that we've talked for quite a long time. I think we've probably talked about, and it's quite obvious that we feel this is very beneficial to individuals, but also health professionals. I guess it's also beneficial to organisations. And I don't know if anybody has any thoughts about that as to why it's beneficial to organisations.
Well, certainly for us in the ambulance service, if we're bringing a patient into hospital that perhaps shouldn't have been conveyed in the first place, we are then delayed outside of the emergency department, which then means an ambulance is not out in the community dealing with other patients. That's one more bed taken up in the emergency department that could be used by somebody else, when to begin with that patient should have been kept at home in their own bed, in their own surroundings. So that larger impact it has. It also impacts patients in the community that can't get an ambulance because that ambulance is with that patient stuck outside of an emergency department. So
it actually
has a knock-on effect.
It doesn't just benefit the organisation, it benefits society.
Absolutely.
Is the way we're going.
Yeah.
And actually doing what matters to a person often means that we are benefiting society, because we're not just automatically doing all these very expensive tests if the person doesn't want them. And society doesn't have a lot of money. You know, the NHS isn't rich in the end.
Yep.
So I guess it actually makes the whole world go round. This talking about stuff and making plans for the future. think we've probably talked long enough. Can I thank you all for coming and chatting to me? It's been lovely. As always, you know I will always talk about respect for as long as possible. Is there anything else you think we've missed or we need to say or correct? Silence is golden again. So, yes, thank you for listening. I hope you've learnt something. I hope you've found it interesting, or at least that we've confirmed what you already knew when it comes to the ReSPECT process and a ReSPECT plan. And if you haven't learnt anything this time, please come back and listen next time, because I'm sure you'll learn something at that point. Thanks. Bye.